Um, Welcome to the Elephant COVID 2019 conversations. Today, I am in conversation with Dr. Richard Ayah. Dr. Richard Ayah is the director of the University of Nairobi Science and Technology Park. And he is an expert, a lecturer actually, professor of health policy and health systems as well. Now, if in other countries, Dr. Richard Ayah would be called Doctor because he holds a PhD in public health from the University of Nairobi, an MSc in public health also from the London School of Hygiene and Tropical Medicine, and a medical degree from the University of Nairobi. So that makes him Doctor times 2, which is
it does say those kind of yeah.
Dr. Richard Ayah. As he's really the right person to talk to us about to discuss the public health crisis, because that's actually his area of expertise and academic work. He's been advised the WHO, the UNFPA, and many other bodies that are dealing with this at the global level. He has been quite prolific, I must say, in the last couple of weeks, writing commentaries to educate the public about the nature of this. I've learned a lot actually following what you're writing, trying to break this down, because some of the things we are sort of reading out there and trying to understand what's going on are quite technical. But I want to sort of start on a personal note. Just how are you having to adjust yourself and cope with the sheltering in place, change in terms of your family, social, work life? What are you finding as the most challenging aspect of this pandemic?
Thanks, David. I don't know whether to say challenging or almost enjoying, huh?
Really?
Yeah. I mean, the lack of traffic is fantastic.
Okay.
I think the main challenge of working from home for extended period of time is, of course, the lack of organization, the self-discipline needed to be able to sit and do something at the right time. So I'm sure you know, if you're writing, it may come to you that you want to write at midnight, and yet it's time. You know, if you're doing a regular thing, you'd know that you'd have to be up at 6 tomorrow, so you'd have to do this thing earlier.
Yeah.
But now it looks like you can go into the next day and so on. So I think that lack of discipline in terms of getting a good schedule is an issue. We have two of the younger kids at home. So they're sort of enjoying themselves a little bit in terms of having people around, but at the same time, not so much, because they keep on saying, oh, you're working on all these Zoom calls. Mm-hmm. But I can tell you that one of the now the frustrations is this, because we run the Makerspace Lab, and when the university closed down, that was one of the first things that was closed. Mm-hmm. So you know about the chronic underfunding that exists in the university. So closing it down and then with the chronic underfunding means that we've in a way been slow to respond to the needs that exist. So that for me has been a bit of an annoyance, in the sense that we were sort of not too fast to move. But on the other hand, I think it was a very good decision, because it removed especially the university community away from what I think would have been an epicenter. So that has been a bit frustrating on that side. On the public health side, especially being around Kenyatta Hospital, I literally had to run away, because I think that in the first couple of weeks, particularly among some senior colleagues, they knew that there's just a lack of direction. So people knew there was something coming. They didn't really know what it was, and therefore people were behaving as normal. You know, people still want to call meetings. They still want to carry on as per normal. So I thought, well, this is, in a sense, is dangerous at a personal level. So it's actually better to be away. So that's what I'm saying. It's not a bad thing in a sense. because I think that there are some people who are so wedded to the idea that I must go to the office in order to work that they don't know what to do otherwise. So that's, for me, has been the sort of the good side and the bad side. The ugly side of it is, of course, we're adding weight sitting at home. Huh? So the lack of a gym and whatnot, and the good thing about it though is that I'm eating home cooked meals.
Yes.
So every single meal is home cooked. I love cooking, so it allows me to do stuff. Actually, I like making the food, not cooking the food, but making the food that makes the food.
Yes.
So that has been really good. The frustration again is that I can't go to the farm.
Yep.
So I have a fairly large pig farm.
Okay.
And also doing some horticulture, trying to get people in Kisumu to appreciate stuff. So we started doing some good stuff, but I can't go there now.
Okay.
So we have a lot of capsicum sort of going to waste at the moment. Sad.
Oh dear. Yeah. So food is going to waste on the farm while we actually need
food is going to waste on the farm. Yeah.
Because farmers cannot go to their farm across county lines.
I mean, you can't. Yes, you can't move. You can't move stuff. So,
yes,
and you know, markets were closed.
Yep.
Initially, yeah. So it's frustrating.
Yeah. Let me come back to the point you made about people wanting to go back to normal, to go on as normal. I have noticed that as well, and I'm quite struck by how determined people are to wish this thing away and hope that it's going to go away quickly. And I'm quite struck by saying that was even in the public health school. Isn't that a bit strange that the medical school is the place we would have expected the most rapid behavior change? And you're saying that that's a place where people are also trying to cling to the idea of normalcy and not appreciating just how the sort of significance, the significance of this. What's your take on that?
I think it's so let me just go back one step. So one of the things I look at is the history of health systems. And one of the things that really, the thing that I try to read up on is why our health system is the way it is. So part of it is embedded in, of course, we're following a Western system of healthcare. But at the root, a health system has to be embedded in the culture of the people in terms of how you interpret it and how it comes about. And I think the best example of that is if you look at, say, the way that the British are so proud of their National Health Service.
Yeah.
If you go to Germany as well, you'll find they're very proud of their system. And it's grown from their own history and culture. So one of the things that I've been reading up on is why our health system is the way it is. And I want to relate this to the way in which the last big sort of pandemic, apart from the one in '68, the one that people tried to measure against is the 1917-18 pandemic.
Yep.
Now, that pandemic is what led to the creation of schools of public health across the world. So before that, there was sort of tropical medicine and so on related to missionaries coming out in the tropics and so on. But the idea of creating a public school of public health away from a school of medicine sort of started in the 1920s as a result of what people saw. So some of the most famous schools of public health then started from there. The effort to build, as in physical buildings around the world of schools of public health, kind of ended in the 1980s. When people thought, well, we sorted out smallpox, polio is sorted out, TB looks like it's almost finished. So we're done with that phase. So then HIV came along, and depending on which country you are, HIV is either a school of public health issue or a school of medicine issue. So in this country, it's a school of medicine. Look it up, because we didn't have a school of public health at that time when HIV came up. If you go across to Uganda, it's a school of public health. because they had just come out of their war and so on, and a lot of doctors were not there. So there's that sort of historical context. So when you come to this country, and one of the things sort of always writing about is that we have a very weak health system. Our public health system is almost non-existent. So we have, within that weakness of the entire health system, there's a lot of weakness now on the public health side.
Okay.
So the School of Medicine is stronger.
Okay.
So when you get sort of now I'm trying to get into the thing of people. So when you get into an issue where now you have a public health problem coming at you,
okay,
you've got essentially clinicians
okay,
scrambling to figure out, they're looking for patients.
Okay.
You know, but the problem hasn't come yet.
Okay.
So it's a public health
issue
and issue. And you know, one of the difficulties of public health is that success is measured by an event not happening.
Mm-hmm.
You know, whereas on the curative side, an event is marked by you came sick and now you're cured.
You're cured.
Thank you very much, doctor. So you appreciate what the doctor has done for you because you came feeling bad and now you feel better.
Mm-hmm.
Public health success is that the event never happened.
It never happened. It was prevented.
It was prevented. So that's success.
Yeah.
So I think in that initial bit, when people are waiting for, you know, we won't see those videos of Italy and what have you, guys who are preparing to start seeing patients. And if the patient hasn't come, I can continue.
Yep.
You know, not so it's dawning on people slowly that within health, it's a health problem, yes, but within health, it's a public health problem first.
Yeah.
So when you hear people talking about ventilators, what have you, and so on, that's a clinical problem.
Clinical response.
Yes, people have a clinical response.
Mm-hmm.
The public health response has been so much weaker because we don't have it. We do not have a public health infrastructure.
So now you bring something I've been hearing a lot, which is questioning of what we are saying patient-centered sort of medicine.
Yeah.
Is that the manifestation of that phenomena? That a clinical-based health system is patient-centered, and therefore it doesn't understand which are not the needs of people. It cannot relate.
Yes, I mean,
to health response.
You can't relate
to non-curative health responses.
Yes, that's the challenge that we're having. I mean, fundamentally, I mean, if you look at I mean, we from if you look at our history, we're a very doctor dominated. The health Ministry of Health has been very doctor dominated.
Okay.
So very clinical. So we like the idea, and politicians as well love that. They like the idea of building a hospital. How many doctors do we have, and that kind of a thing. Huh? That is important because that's where even your leadership comes from. But it neglects this other side, of which it is very difficult to like I said, success is it didn't happen.
Yes.
So there is you will look to find a politician who has gone to get involved in, say, child vaccination.
Yes.
You know that today I'm involved in, you know, to make sure that children are vaccinated because there's nothing. How will you show success if it's not
vaccinated
there?
So they were vaccinated, so they didn't get sick.
They didn't get sick. So you find like our vaccination program, for example, is entirely donor funded.
Yeah.
Okay. Our TB program is entirely donor funded. Our HIV program is almost entirely donor funded because these are preventive issues. You know, so I think it's a political calculation and maybe it's an economic one where we say, okay, so these guys are willing to give money for this, so let's focus our resources on
what they're not going to fund.
So one of the tragedies that exists, yes, what they're not going to fund. So nobody's going to fund training of doctors, for example, because there's a global shortage. Yeah. So you have to train your own doctors. In a similar way, nobody really cares about your own people's health. Ultimately, it's your responsibility as a country to take care of your own people's health.
Yeah.
People only come in when your being unhealthy is a danger to them. So that's where the HIV comes in and so on, and that's why they're willing to invest in countries such as us. So I think that's where we've had an issue. That
it's very insightful. In fact, it takes us now to the next issue about the things you've been writing, which I sort of was hoping you can elaborate a bit on. Your most recent, I think it was commentary, you said the first wave of COVID-19 is likely to hit health facilities for this coming week. And then there's another one you wrote before with some of your colleagues, which was a bit more technical, saying that flattening COVID-19 curve by protecting patients with comorbid conditions. That's the title. Now, it seems to me that these two titles actually seem to summarize where we are. One, the rubber is about to hit the road in terms of now the clinical cases, but also that what we need to do in terms of the response is protecting the vulnerable. And the vulnerable is people with chronic condition. So what does that say in terms of your sense of our exposure to the pandemic and our preparedness to deal with it? Because that seems to be what you're addressing.
Yeah, I mean, it sort of builds up on what I was saying. So we've got, if I just divide arbitrarily, sort of two groups of vulnerabilities around people with chronic conditions. One of them is that there's a knowledge gap. We do not know, for example, what effect COVID will have on people with, say, HIV. And we have one of the highest burdens of HIV in the world. So we're following what, countries are reporting what are their vulnerabilities. So their vulnerabilities, they don't have a lot of infectious disease, they have a lot of non-communicable, particularly in the elderly. So that's what they've been reporting. Now, we have a double burden. So we have a significant amount of non-communicable. It happens in people who are 10 to 15 years younger than happens in the West. So if you're talking about 70, 80-year-olds, here you'll be talking about 50 to 60-year-olds. So that's a vulnerability. So you're talking about people who are just, if they're working people, they're just about to retire. Those are the people who will have a comorbidity. They're the vulnerable groups. So when you start looking at this thing, for example, at University of Nairobi and literally all these other universities, we've had this problem of not hiring for more than 10, 20 years. So we have a huge number of professors who have these comorbidities, who are a very vulnerable group. So you could go and do an analysis almost by institution. And I think the public service also has a bit of that as well, the civil service, where you find that group. So the question is, how do you protect that group? So that's one question. So we could follow what has happened in the West, and really the picture is a horrible one. I've had messages coming in and people sort of seniors, you say, Dr. So-and-so, Professor So-and-so passed away COVID, he was 73. So that's knowledge you're losing. And if that in our society, you don't need to lose too many people like that to really just finish, just as an example, higher education. You will not find many professors in any one particular field. So 2, 3 of them going prematurely is a disaster for us. So looking at that group. So the two things I'm saying is that, one, there's what we know from other countries, about conditions like diabetes, hypertension, and so on. And then there's what we don't know. which is almost an African problem, which is around infectious disease. I'll give you one little example. Just happened to hear of one of the patients, and not 100% sure this is true, but that one of the patients who died from COVID also had dengue fever.
Wow.
Now, when I heard that, and dengue fever is if malaria is painful, dengue fever is even more painful. Now, to get both, so the dengue fever made things worse. The COVID attacked the lungs, the dengue attacked the liver and the stomach and so on, and the patient passed away. Now, dengue is something that has just come back into this country in the last 5-6 years, in terms of episodes because of our poor public health systems. So sanitation, what have you. So we've seen a resurgence of conditions like that really at some point had gone. We didn't have cholera 10 years ago. It's come back every year we report one town or the other has cholera. So the question will be, how will cholera react with COVID, for example? So those are things we don't know, simply because we haven't seen. So those to me were the things that we need to start to protect against. Now, one calls for a very concerted effort in terms of public health investment, in terms of just the surveillance and so on, which is lacking. And the other one is a lot of these comorbidities, and remember, things like hypertension, diabetes, you pay for it yourself. It's not covered by insurance and so on. So a lot of the data is sitting in private hands. It's in individual hands. So to get to know who has this condition and who doesn't have and so on, there's really no public register. But for HIV, for TB, there is. But it's sitting in donors' hands.
Yeah.
Because these are things that, as a country, we decided let donors fund them.
Okay.
Yes. So if we got some of these NGOs to work with government, remember they have a mandate because they're being given money to manage, say, HIV. And by the way,
funded NGOs.
Yes. And because government has neglected public health, some of our very best brains, other than those who are abroad, are sitting in these NGOs. They're tied because then they serve their master. So unless they let loose and say, guys, pay attention to this, they have a very narrow mandate because their funding is tied into this. So and I've been talking to some of them. I'm associated with a couple of them, and one of the issues is that frustration, where you're Kenyan, but you can't go out and do stuff because this is what pays your salary. Yeah. And the second thing about that is that some of these organizations are very, very good at doing the kind of things that the ministry is trying to do. This contact tracing, surveillance, what have you, and so on. They've been doing it for years and years around HIV. So right now, the ministry is trying to
reinvent the wheel.
Do something, reinvent the wheel. We're hiring afresh, we want to do this and that. And we have these organizations sitting who actually are very good at this.
And we don't know whether they have been mobilized. We don't get a sense they've been mobilized.
I don't think they've been mobilized. It's like having a foreign base. The assets are owned by someone else. Yeah. I mean, that the testing is being done in CDC, the Camry, but CDC.
Yeah.
So
that's the state of play.
That's the state of play. Essentially, our best public health infrastructure is foreign owned.
That's the long and short.
That means.
We focused on the clinical. We left the public health side to donors.
Yeah.
So that's and our patient-centered clinical health system really isn't prepared for this. That's
not prepared
it's
because it has nothing. It has
yeah, it's not
nothing to.
designed.
It's not designed.
It's not designed for this.
Yeah.
Now
Yeah.
that's you're not only a clinician, of course, by training, a public
Yeah.
health professional. You've done healthcare management. You've done socioeconomic development. I know you did quite a bit of socioeconomic development, so that gives you a very broad and multidimensional sort of vista on how this crisis is likely to evolve on all those dimensions. And I was quite struck by how you're bringing some of these things together, like the Google data you posted, showing that while visits to recreational and retail centers have declined since we imposed this sort of partial lockdown, socializing in the estates has actually gone up, sort of compensating. So people are not going to malls, but they're hanging out in the estate where they can.
Yeah.
That's the sort of that seems to suggest to me. Now, that seems to suggest that the social distancing protocol we have adopted may actually not be effective because we just copied, downloaded these from what the West is doing. We've also observed that the tests we are using have 67% or so efficacy, and that's usually more reliable when the caseload is quite high. It doesn't tell you so much when the caseload is low. And what I found myself asking, since there is that information, is to ask myself, are we really on top?
Yeah.
Do we actually know what is out there? What's your sense of what is out there vis-a-vis what we think we know?
Yeah. So one of the questions that we need to answer is what our strategy is. Like what are we trying to achieve in the end? So there've been conflicting reports about the effectiveness of COVID. So initially the sort of range, like, can you be infected if from somebody who's, say, asymptomatic?
Yeah.
And what I'm reading now is that no, the people who infect others tend to be those who have either started developing symptoms or will develop symptoms. So there's that kind of a window. So just back to the question. So majority of people will get some mild or no symptoms at all. So we're worried about those who become seriously ill. Where will they go? So that's the health system problem. That about overwhelming and all this talk about flattening the curve and all that stuff. And it's about managing the numbers that come forward.
Okay.
Now, the interesting thing is that, and this is the thing about the West, is that despite all the stories of all the systems being overwhelmed and all that kind of stuff, they still manage to stay open. Even when they said, yeah, people are dying and stuff, but the hospitals still manage to stay open. I'll give a little example. Some years back, about 5, 6 years, 8 years now, I did a fellowship in Baltimore. Population about 500,000. They had about 5,000 doctors serving the city. They also had about 5,000 lecturers as well. Now, at that time, the total number of doctors in Kenya was about 7,000 or 8,000. We now have about 10,000 or 11,000. So one city in the US has maybe half the number of doctors that Kenya has in total. So they have capacity. Now, when you come to our country, and I'll give you like an example. We had one patient walk into Aga Khan, and before they diagnose, they had to, before they figured out that this was the thing, people had to go into self-quarantine. So it doesn't take more than 2 or 3 patients to shut down any particular health facility in Kenya.
Wow.
Because they'll go for 14 days. So that is the health system challenge that exists. That if a person walks into a facility and the preparedness is not 100%, and you get some kind of suspicion that maybe you have been infected, all of you have to go off for your 14 days for observation. So it happens day one, that crew goes off, another one comes in. Day two, another one crew comes in. By day three, those are all your health workers at home or somewhere in quarantine. So who takes care of the fourth patient and or all the others who are coming in with now those comorbidities that we're talking about. So we're very, so that speaks to like what is the these numbers we're getting, what is the strategy, what are we trying to achieve? So the numbers themselves don't really matter because it doesn't take many numbers to shut us down. What matters is our level of preparedness. Do you have enough PPEs? Do you have the protocols in place? So I'll give you an example. If you walk into a big casualty like KNH, the protocol you expect, say for a mass accident, is a trigger of codes. That says we've got a call. Say if it was a road crash, we think there are 50 people who have been injured. So that should trigger a series of people arriving in the casualty to take care of 50 people. And then after they've assessed, then they can disperse back. So some kind of crisis management protocol. That's what you need for COVID. It's really a detailed operational plan that says, if a patient walks into our facility, this is how we will manage it so that we don't knock off our health workers. Now, that bit of level of preparedness, a couple of private hospitals, I think, are managing to do it. Most public are not. We haven't. That's a weakness that exists. So even a few suspected COVID could knock our health system down, and then you're in trouble. This is before we deal with the thing of stigma and the fear that is going on.
Now, if a few cases of COVID can knock out the health system, so we are saying the risk that we are facing is not just COVID, but a collapse of the health system, which then the other ailments have not gone anywhere. So you end up with an increase in mortality from all diseases.
Yes.
Because your health system cannot respond. That's what I'm hearing.
That's essentially what I think we're facing. And it's both the immediate, because you're talking about, for example, if you're knocked off a few, your health workers are in quarantine and you get a road accident, you just don't have Dr. So-and-so or so-and-so to come to take care because they're locked up somewhere.
Yeah.
So that's one aspect of it. The other one is that a lot of facilities have closed off to people with recurring appointments. So people coming for antenatal care, people coming for the diabetic clinic, they were told stay away. So they're going to start coming back in crisis. Now, when that happens, so you're looking at an effect. It's kind of like I think now there's a paper been published on that. The effects of doctor strikes.
Okay.
When patients are told to go away, you don't see it immediately, but the mortality rate spikes.
Yeah.
There's an immediate spike in mortality rates around. Actually, I do have some data for Kiambu County a couple of years ago, doctor strike, where the mortality rates in all the other hospitals went up. But Kiambu, of course, because there are no patients, their mortality, they look really good, because suddenly there are no mothers dying in the facilities, but they were dying elsewhere.
Yeah.
But longer term, you now see the effects of you missed your medication for a month or 2 months. Then you begin to see that effect longer term. So that's what COVID is doing.
Okay. This is
quite gloomy.
unsettling. I must say it is actually more unsettling than I was prepared for. Which brings me now to scenarios. There are lots of them out there about how this thing might evolve. The UK started out with a herd immunity strategy, and that seems to have unraveled very quickly. It seems to have gone horribly wrong very quickly, including by the Prime Minister getting infected. So, so they had to back down.
Most unfortunately, yes. Yeah.
And it looks like actually the US may have been on that strategy as well, without saying so. And that seems to have backfired very quickly. But most countries seem to be on what I might call a sledgehammer strategy. That if you do one big shelter in place for a month, you then isolate all the cases that are infected and they are treated like China did, and then you put it up. That seems to be what most countries, I think, are hoping this is going to be a one-shot game.
Yeah.
You do it once, it's over, you go back to life as normal. Then you have the wave scenario that you may get this thing, one economics professor called it a whack-a-mole scenario. Global it here, it pops up there, you try and global it there, it comes out, and we are beginning to see some of that because Japan, I think northern Japan, into emergency. Some loud noise at the back. I don't know. Can you hear some loud noise? Some people talking loud.
Those are children.
Okay.
Sorry about that.
That's all right.
Excited. Yeah.
So Japan, they opened up, then quickly they've gone back to emergency. Singapore opened up. They also seem to be going back to a partial emergency. So we're seeing a bit of the wave sort of thing. There is the Spanish influenza scenario where the thing may go into hibernation during the warm months and then come back with a vengeance when the northern winter returns. What's your take on all these scenarios? I see our people here don't want to hear that we should dig in for the long while. You know, when I said that on TV, some politicians reacted very quickly that it's not scientific. What's your take on these scenarios? Herd immunity, the time frame for a vaccine, all these sort of anxieties that people have. What's your sense of it?
I mean, I think the reality of it is that there's so first of all, there's a fundamental change. So we're not going back to where we were before. So if we open up in quotes and we go back to where we were before, we're courting disaster. So give an example. So when we started, one of the things the county governments were doing was some sanitation, going around spraying stuff and that kind of. They stopped pretty quickly. I've not heard too much of that going on. But those are the things that need to happen like forever.
Okay.
We're going to have to up our game in terms of sanitation. Public health. Sanitation. So you can't go back to sort of street food, this hand washing thing and picking up. So that's something politicians are going to have a very hard time dealing with, because these are your sort of voters, people doing their small businesses and that kind of thing. I know, for example, in Kisumu City, the governor had a hard time trying to close down some very unhygienic eateries that have existed for years, because we pride ourselves that that's where we want to go and eat. That's what is African, to go and eat in a place where there are flies all over, there's rubbish next to it, and you're doing your car wash and that kind of thing. That has to die. We're not going back there. So what's going to replace that? So and there's a cost to it in terms of and you can think it all the way through in our culture, because that system of that hawker or that little eatery or by the roadside, that thing was running a corrupt, pay me daily kind of a shakedown kind of a thing.
System, yep.
It's a system. It's a whole system. Now, that system is what prevents, because it's a vested interest, what prevents that county person from investing in the right thing.
Because you can pay off the compliance people.
Yeah. Yes. So I do my daily thing, and I was reading a report from, I think it's from 1926, where the colonial government was saying that they didn't want to employ sanitary inspectors who are African. And they said they were not going to do that as the colonial government because they felt that this was something that should be done by the native councils.
Yep.
And the issue was supervision, because they said this sanitary inspector is going to be telling people something they don't want to do.
Mm-hmm.
There's a cost to being clean.
Mm.
So the guy who comes to tell you that is a bad guy.
Mm.
So it requires you can't come and instruct people. You need to persuade them that it is in their interest to do this. It's for the common good. So that means that even our governance structure, and I think that was part of the whole thing about county stuff, has to change from being a policing kind of, I'm coming to shut you down. It has to be a more educative, I'm coming to show you how to keep your place clean. And then eventually I will throw the whatever at you if you don't do it, but I have to train you and equip you and make sure that you're able to do it. So those are the changes I'm seeing have to happen. Now, when you go back to this thing about whether you're hammering, you're flattening, and so on, as guys have rightly pointed out, we don't have a curve to hammer because we're not testing. So, and we're unlikely to test because the global politics says that we're not going to get the tests that we need. The disease itself is so early in its time. The test that is being used, like you said, is only about 67% efficacious. So, and already they're saying there's some people who are turning positive after turning negative. So until we get way better tests, we really don't have a way we can't test our way out of it. In other words, we've had HIV for 30 years. We have not able to test our way out of it. Though the current strategy is to do that in some areas. I mean, if you're in Siaya or Makweni or whatever, the PEP for funding, CDC funding, is to test every single person. And already we have seen some results of that. The prevalence rates have come down simply by the people who have been tested like every 3-4 months. If you walk into any health facility in Siaya, you will be tested for HIV.
For HIV.
Yes, that we want to test everybody. So that strategy has been there in a way to get people into care, because there is a treatment, which is to put people on antiretrovirals.
Yes.
Here, we don't have a treatment. So even if you were to test everybody, suppose we could afford it.
What do you do?
What do you do? Yeah. So we have to think it another way, but we can't test our way out of it.
Okay. You say now, should we be adopting the mindset of a disease that's going to become endemic and dig in? Because the mindset now is that this is a passing cloud. I have argued that it's not a passing cloud economically, because the effects are going to play, because the economic effects are not coming from the pathogen, they are coming from fear of death. Yeah, and fear of death is not going to go away. So, and if people are reacting economically from fear of death, there is no system of incentives that can change that. We have no policies to respond to fear of death. Now, drawing a parallel, you made a suggestion that I came across, that perhaps we should be thinking about special small hospital units that deal with the COVID-19 to be put in place across the country, and then we release the rest of the health system to go back to its business as usual. And that struck me as a strategy of accepting that we are in for at least the medium haul, if not the long haul. Is that sort of your kind of thinking, or is that what informed that kind of thinking?
I mean, yeah. I mean, thinking about it aloud, I think. Okay, so one is, and this you can disregard, is that we are Africans. So Africans, we are at the bottom of everything.
Mm-hmm.
So is it going to be endemic? I reckon so.
Mm-hmm.
It's not going away soon. So we just added to the list of diseases that we have.
Absolutely, yeah.
Yeah, and we have many. So we add it. However, it causes the change that I've been talking about in terms of the level of preparedness that is needed. The disease does not tolerate poor sanitation, both from a personal perspective and the general environment. So in that sense, it's about time that people sort of styled up. So it may dip in terms of its incidence because of all these things that are being done, but it's still going to spread.
Okay.
It's still going to spread. So
it is here.
we're going, it is here, and right now we're going into our pneumonia season.
Yep.
So our pneumonia season starts now and goes all the way through to July.
Okay.
So we expect just by that alone. So the lucky thing about our pneumonia is that between the adult pneumonia and the childhood pneumonia, it's been the childhood pneumonia that has been killing Kenyans. Adults get it, but sort of survive. But this is the season. So COVID is manifesting as a pneumonia. So you kind of expect that, at least my reckoning is that it's just going to add to the morbidity and mortality around pneumonia, at least for the next 3 months.
At least 3 months.
So the question then comes, so how do you manage? I reckon at least 3 months until the pneumonia season ends. Then we figure out what to do. So the question is, can you afford a lockdown until then? I don't think so. I really don't think so. So the same, and you see, if you're lowering the incidence of pneumonia, it's the very same strategies we're doing right now.
Okay.
Hand washing, social distancing, and so on, because that's how pneumonia spreads in general.
Okay.
Yeah.
So we should mainstream it.
That to me is the lesson. The big lesson out of this is that we have had these communicable diseases that decent sanitation and good personal habit would sort out.
Okay.
So if we're able to effect that, then in a sense, we would flatten the curve for all these infectious diseases.
Okay.
Yeah, and COVID will be inside there somewhere.
So COVID joins our list of infectious diseases that we need to deal with and bring down. It is a very virulent common cold in a way, in terms of the fact that it is passed on very easily.
Yeah.
But it can kill.
Yes, and the way it kills is very dramatic.
Yeah.
I think that's why it catches people.
Yeah.
There's no, you're kind of mild for a day and you go downhill in hours.
Wow.
Yeah, that's the fear factor in it.
Yeah.
So it's not a TB that you can watch somebody for months on end go down slowly.
Yeah.
And you can sort of try and arrest. So that's the drama around it.
Do we have any other disease with such sort of manifestation? Ebola, perhaps, I don't know.
Ebola, maybe, yeah, because of adults. But childhood pneumonia is almost exactly like this. A child, a 2-year-old can be playing in the morning, have some runny nose and so on, develop pneumonia, and be in critical condition by 10 p.m.
Okay.
So it's that dramatic when it hits the lungs. The good thing about these sort of pneumonias in childhood is you start them on treatment, and that same child can be playing by 10 a.m. tomorrow.
Okay.
Like 2 days of antibiotics later, you can see some dramatic improvement.
Okay.
So, but in terms of the time, how it happens, it can really be, you can lose a child like that. It's just that for most of us, we never see that. Huh? These are things happening amongst poor people. So we don't see it. Yeah.
So now,
Sorry about that. Yeah.
that's all right. Now, that's a very good point to raise my sort of winding down question about the potential public health legacy of COVID-19 on its legacy on medicine, on public health, on our health systems, perhaps even on our policy and politics. Because saying, now this is what we have now, a disease which affects the middle and upper classes in a way that childhood pneumonia and other diseases affect the poor, which I am finding very fascinating. That we are now having the poor people. We have had the nature of the class dynamics of infectious diseases has been that the suburbs are afraid of diseases coming from the slums. Now we have a situation where the slums are afraid of coming from the suburbs. It's a very and that's why perhaps we are seeing these almost hysterical sort of preoccupation with this disease by states, and because it's affecting the wealthy, it's affecting the economy. I'm not sure if it was spreading just among the poor, we would be seeing the same sort of response. But once jet setting people, once you start a disease, people catching in the airplanes, I think that's that's a political economy of it, I guess, perspective I'm bringing. So what are your thoughts on its legacy? You've already alluded to quite a few things that suggest that there should be a major paradigm shift. For instance, from clinical and patient-centered medicine to a more public health and holistic-oriented health system. What are your thoughts on the legacy, also in medical field, in public health, and also in the health systems management?
I mean, some I think are going to be wishful thinking. So first of all, I don't think that we're going to get away from the clinical-centered sort of thinking, simply because there's sort of the way the money skews and the way people understand medicine. But the thing I'm sort of wishing for is, finally, I hope the country, and this I think cuts across all African countries, that they begin to invest in their public health infrastructure. Now, that stems from training, number one. So getting schools of public health functional and working, that's sort of like the far end of it. Like I said, the world stopped building schools of public health in the 1980s. So we don't have that. So that needs to happen. The other bits, I don't know. I worry about one thing, which is when the world, well, by that I mean the West, sorts out and decides, okay, so what's going to happen? Are we going to have a COVID passport? Because one migrant with COVID comes and coughs on an Italian ship.
That's it.
It will cause such a problem.
Yep.
The flip side of it will be that a tourist coming to a Masai Mara, you want to know that the tour driver who deposits you in your posh hotel, where do they go to eat? They go to eat in that kiosk down the road. Is that place COVID free? Because you come back and ride with me for another 3 hours on the way to the airport.
Wow.
So to me, one of the big issues is the idea of, we've existed in essentially what is a colonial apartheid system of health, where we all aspire to be on the private side and we leave the public side for them. So now we have a situation where them is us. So I knew that the reason for perhaps investing in getting to know my shags, doctor and whatnot in the end, is that eventually I retire there. I need to get to know this guy because eventually I can't afford to continue doing the private place. And the day I'm going to die, I'll be rushed to the nearest sub-county hospital.
Mhm.
So there's some incentive to get to know how it is and what it looks like.
Mm.
So if people realize that that choice of flying off to India or South Africa or whatever just doesn't exist, or it may be more dangerous for you.
Mm.
You may go to do A and you come back with B.
With B.
So you have to now begin to sort out our own infrastructure,
Yep.
even in terms of the curative side.
Okay.
Just as an example, we have like 300 MPs.
Yeah.
If you got COVID in 20 or 30 of them, you couldn't accommodate them in any private hospital in Nairobi. They would overwhelm that hospital.
Yep.
So some of them would end up in a public. So for me, the day I see KNH now has a presidential wing, I'll be so happy.
KNH having a presidential suit is
yes.
one of the paradigm shifts.
That to me is one of the whatever. I mean, equip it with everything you want. Make it as fantastic but let it be in a public facility, or it could be in the military hospital. It could be at the Armed Forces Memorial.
But what you're saying
but it should be in public.
is what you find in the West.
Yes.
You find that the top people, the presidents, everybody, when they have serious health issues, they go to the medical hospital.
Yes.
Imperial College Medical Hospital, or in Boston, they'll go to the University Medical Hospital.
Yeah.
And even when they evacuated from here, that's where they're taken.
That's where they're taken anyway. Mm-hmm. So to me, that's one of the things. Now, so that's like in fact, I think I wrote that early on, and then kind of stopped to say that the president is ours. Mm-hmm. So I'm imagining a situation where somebody senior got a disease like COVID, went to a private hospital, mm-hmm. and then next to it was a foreigner with another disease. Mm-hmm. And you catch that, and yet you belong to us. So if we're going to protect our senior people, we should protect them all the way. Yeah. Not just in terms of chase cars and all that, but all the way even in terms of health. So why is it that you reach a certain point and now suddenly you're in a private vehicle? You would not allow that, would you?
Interesting. So you put them on a motorcade and you protect them, and you have all these GSUs. And then they get sick and they go to a hospital in India. And then mm-hmm. they are not protected from the pathogens.
They're not. Yes. Yeah.
So they come back now with an Indian pathogen, which they don't have immunity.
Yes. Because now you're just somebody with a lot of money. When you're abroad, fine, you may be a dignitary and all that, but you're just somebody with a lot of money. Mm-hmm. Whereas here you're representing us.
Yeah.
So we look after you. So that's at the sort of the bigger level. So this apartheid system of private wings and all that kind of stuff to try and protect certain people. You can have the hotel services, that's fine. But in terms of the healthcare itself, it really has to be for everyone. So if that happens, fine. The medicine, it has to be. It has to be. That would be a really good thing. Yeah. The other one, which still continues even up to now, is now within health. We have a situation where our top researchers don't own the hospital that they work in. Mm-hmm. Right? So they don't have, in a sense, skin in the game.
Yep.
So you have, and it's just happened again, even though people thought it would happen differently. KU built a hospital, it's been taken over by the Ministry of Health. They create a separate parastatal for it because you know why.
Yeah.
So now the doctors and lecturers who are working in KU, the School of Medicine, will be in effect visitors to the hospital.
To their teaching hospital.
To the teaching hospital.
Yeah.
The same sort of thing that's happening in Nairobi University like forever and ever. Yeah. You have Kenyatta and you have University of Nairobi School of Medicine. Mm-hmm. So Kisumu as well, Maseno. doesn't own the hospital, or vice versa. So you don't have a teaching and research hospital. The research that Kenyatta as in itself does is fairly minimal compared to the amount of research that the School of Medicine does.
Okay.
So you don't get the very best you can by splitting.
Yeah. You have siloed.
You're siloed, yes. You say you guys teach. Yes, you guys teach. And therefore the kind of patients who come to KNH, you see, if you have a teaching and research hospital and your main functions will be very, very good, then the kind of patients who you see will be focused around research. And that's how you get to be very good.
Yeah.
So I'll give you an example of, there is a colleague who's is trained in ankle surgery. So he's an orthopedic surgeon, and then he trains specifically around the foot ankle surgery. He can't get enough cases after being trained. Why? Because the system does not direct such cases to him.
Okay.
Now, while he in charge of the hospital where he worked, he's in the School of Medicine, while he in charge of the hospital where he worked, then he'd be able to channel such patients. He'd be able to direct and say, all patients with an ankle problem, come to this clinic on Tuesdays.
Yeah.
You know, so you see that even in the response. If you ask yourself, the ministry came and said, Kenyatta Hospital, we're directing you to set up a COVID ABCD, right? As a parastatal. But if you look at who are the experts, they're coming from the School of Medicine, of course, with a few from elsewhere. So they're split. When it comes now to saying, I instruct you to do something, the CS for Health has to look for, this person is in half in Ministry of Education, this person is in Ministry of Health. So those are the things that slow down the responses that are expected. So to me, those are some of now, when you go to the institutional level, you sort of big level, you go to the institutional level, that hopefully will, if somebody is brave enough to change, would begin to look at that and promote some efficiencies around that.
Okay. Any other final thoughts?
I think the whole thing has been kind of gloomy.
Yeah.
In so far as, because there's so much uncertainty around it. So it's very difficult to look for, I don't want to call it lining or silver lining, but I think the fact that as a country we don't have those many economic layers, people are still quite close to sort of primary bits of production. I think saves us in a way.
Subsistence, yeah.
Subsistence, yeah, saves us in a way. So a lot of people are kind of detached from what's going on economically. So it affects them, but it just makes them poorer, but they were poor to begin with.
They are a bit of shock absorbers.
Yes, yeah. So, but it's a shock absorber at a very low level.
That's very low level, yeah.
Yeah. So it allows. So there's lots of room for improvement if we can sort of style up and get a few things right. And one of them is to get this idea that, and that's what COVID tells me, that you and I are the same.
Yeah.
My maid and me are the same. We're both locked up here the same.
Yeah.
So if something happens, we're both going to Baghdadi the same.
Yep.
So if that comes across, then something will have happened.
A sense of equality in something.
Yeah.
A sense of equality in something. That's a good point to add. Thank you very much, Dr. Ayah.
Yeah, thanks.
You have obviously proved your worth in terms of your double doctor. The philosophy side of things, as well as the medical side of things. And I do hope that some of these things get picked up, particularly because it sounds like some of these things, they are things that we as intellectuals and professionals can actually do without waiting for the politicians. I mean, in terms of changing the paradigm in terms of our health system is something that we can actually do. Because this time round, I'm also optimistic that hopefully that when politicians realize that there are circumstances that they will not be able to go to US or UK or India, maybe we may have a bit of traction in terms of sort of policy and institutional change. So thank you very much. I hope we can pick up this again as things evolve.
No, thank you very much. I mean, we'll talk some more.
We'll talk some more, absolutely.
Yeah, thank you. Thank you so much for the privilege.
Okay,
yeah,
thanks. Thanks.
Yeah.